To come into the venue, please. Ladies and gentlemen, please take your seats. Thank you very much. As participants of this meeting sets in into this room, do I have your attention? Do I have your attention, please? Do I have your attention? Can you raise your hands to indicate that? Excellent. We all are waving well now. Now that we are returning from the lunch break, I hope you have stuffed yourself well. The problem sitting after lunch is that the after lunch depression, whereby they say most of the blood in your body goes to your stomach to serve the food, and your mind gets denatured of blood. I hope that will not happen, and in light of that consideration, we have made the sessions to be only 2 sessions in the afternoon, and each of them are separated with a break as well. While I request everyone to remain attentive for the next 2 panels, as we are embarking on this idea of ending preventable child and maternal deaths and the need to act on the call by overcoming critical barriers, we were trying to see how we are flying, how this agenda is flying on the social media as well. And I tell you, we are flying high. So Crowd 360, with FHI 360, is doing a live tweets, and also the handle acting on the call, which is AOTC 2017, is also doing the same. And the hashtag Mommy and Baby is also continuing and flying on. So far, we have 5,700 views of the tweets from Crowd 360. And the acting on the call handle at AOTC 2017 has 30,000 impressions, which are 20,000 are the new impressions we have this morning. I think it deserves a round of applause. You are not the only one attending it. People from the entire part of the world are attending this conference, sharing their ideas, tweeting whatever you're saying in here. So this is an encouragement for all of you to keep on tweeting, to share your ideas, and also endorse whatever is being said on the panel. While having all this, at the end of the day, I will also share you the detailed narratives of the summaries of the entire social media and audiovisual media activities. Now this is time for us to continue to the third session, which is entitled Improving Quality. We might do several things on equity. We might appreciate the progress we have done, but without ensuring quality service available in health facilities, our narrative would be empty. We know that mothers prefer, the critical things that mothers prefer to have in facilities is to be served by a facility that has the required inputs, drugs, and supplies, and at the second level, they require health workers to be compassionate, respectful, and caring. I am quoting an existing evidence. So as in the previous session, even though in God we trust, in programs we need evidence, now we proceed to the next session of having a quality session, discussion, to be moderated by a dear colleague and friend, Dr. Felicitas Zawaira, who will be moderating the next session, and I kindly call upon the panel to take their seats, please. The moderator of this session, Dr. Felicitas Zawaira, she is the director of the Family and Reproductive Health Cluster at the World Health Organization, and she leads a team of technical staff working at the regional office and inter-country support teams. At the area of reproductive and women health, child, adolescent health and nutrition, as well as immunization. Dr. Zawaira, she has a great experience and quite extensive one in management methods and of international health, and also managing regional programs at an Africa level. Dr. Zawaira, please.
Thanks, Ephraim. Good afternoon, honorable ministers, excellencies, ladies and gentlemen. Good afternoon. I know I'm standing between your lunch and your sleep, but we hope to keep you awake and alive in the next session. So, as Ephraim has said, this session is talking about quality of care. I'm just going to set the scene for you. Imagine a hospital where the patient's notes are written on a piece of cardboard box. Are we going to be able to do any maternal death audit after that? Imagine a health facility with no water. The midwife actually has to get up in the morning and go and fetch water for the clinic from a bowl with a bucket. Imagine an upper middle income country that I visited this year, where a woman was delivering on the actual ward, not in the labor ward, with everybody watching. What dignity are we talking about when we talk about quality of care? When we have said we've made progress, as you saw, people were looking at coverages. We heard earlier, coverages cover a lot of things. Underneath that, they cover poor quality. Someone asked, what are we going to do to bend the curve of maternal mortality? And the only thing that is going to bend the curve, when we as WHO have supported countries to do their reviews, we realize coverage is one side of the story. But if the quality of care is not good enough, we are not going to get anywhere. So this afternoon, I have a distinguished panel to take us through quality of care. And we are going to start off with Feli. And she works, but please tell them exactly what you do on a day-to-day basis. Where are we going wrong with quality of care? Are we getting there or not? Please come over.
Thank you, Felicitas, almost my namesake. I think as she has said, you can see when I'm putting on a uniform like a midwife. I am here to present thousands of voices of midwives to talk on how we can improve quality of care from the midwife's perspective. As I talk, I think you are seeing that picture because during the introduction, she said, I supervise these health facilities, more especially on maternal child health, so that we improve and prevent these deaths of mothers and children during the time of delivery. Now, when we talk about quality of care, what do we mean? World Health Organization, it defines it as the extent to which healthcare service provided to individuals and patient population improve desired health outcomes. And how are we going to achieve this? There has to be safety of a mother, so that as we provide this care, the mother needs to enter in a health facility, and she comes out after giving birth when she's happy and the baby is happy. As we are offering these services, we need so many things to use. Then we need to give it effectively. There we need the scientific knowledge and using the regulatory guidelines. We have to follow that. That means as we are monitoring a mother in labor, we need these guidelines, we need the pathogram, we need everything so that we get a live baby and that remains safe. Then during that time also, we need time. We need to be there. If a mother enters in a clinic or a health facility, as midwives, we have to be there, and we give time to these mothers. Because the more you delay, if you delay, that gives the chance for a mother to get complications, even the fetus. Then we need to give these services equitably, despite the religion, despite where the mother comes from, despite the education background, despite whatever, as you know them. That's when we shall give quality care. And we have to be client-centered, so that every mother who comes in is an individual. We have to treat that mother as an individual. Then, how are we going to do this? First of all, as midwives, we have said we have to be having that knowledge scientifically, and we use the guidelines which are given to us. If we do that, we shall provide quality care. But midwives, you know, they are at the center of giving a mother and a baby, so that we get a live baby. There is nobody amongst us who feels better to go at a health facility. You are going, or you are taking there your mother for delivery, and you see her coming. You get someone now, you go back with a mother in a coffin or a baby in a coffin. Everyone, it touches me as a midwife, and it touches even the relatives, the friends, and even our governments. So what are we going to do so that we improve quality care? First of all, we as midwives, or every stakeholder has to be involved. And the government has to be involved. How? To provide what we are supposed to use. It embarrasses a midwife, because remember, the midwife starts with this woman even before pregnancy. In advising, the midwives have to go back to the communities and they talk to these mothers. The mothers become pregnant when they know that their hemoglobin level is okay. They don't have any other diseases like syphilis. If they have, let them be treated. They have to become pregnant when they are healthy. Their nutritional status is okay. But if we don't go to the community for sensitization, and we use these community health workers and VHTs to help us, because in Uganda we have a component of VHTs, village health teams. I don't know if in other countries you have them. So we have to empower them. You remember there was a video here, and it was showing a mother who is helping, a community health worker who is helping mothers there in the community to deliver. So we are saying we are going back to the communities. That is the role of midwives and even the government. Then the government should provide what is supposed to be provided. For example, it embarrasses a midwife if a woman comes for antenatal. First of all, in Uganda, we are saying we are doing focused antenatal care. That means you have to focus for the mother as an individual, and you have to focus for the trimester differently. First trimester, it is not like second trimester. Second trimester is not like third trimester, like that. And it embarrasses because as a midwife, if a man comes in for the first time, you are supposed to take the blood pressure because you want to monitor as the pregnancy grows. But you'll find that there is no BP machine in the clinic. You find sometimes there is no weighing machine. You find you don't have urine testing kits to see because you want to prevent these diseases or these problems which make these women die. And you, at that time, if you are a midwife, that means you are working like a traditional birth attendant. And if we are given those, that means you will monitor pregnancy from the time you got this mother up to the end, and you can detect any problem when it is still early. Then there are these, like how we have been saying, that we want to have live babies who are safe, and they go home when they are okay. If you don't have these resuscitation devices, that means at the end of it, you will get these babies. I can give you an example why we need sensitization to be very vigilant. In the last 2 months in Uganda, we lost an MP because of pregnancy-related diseases. And the media said the woman was 5 months pregnant, but she had never attended antenatal care. That's why we are saying, let us go down and we give information of the importance of attending antenatal care. Another thing, in those last 3 years, in our district, we had no emergency obstetric care equipment. But we were helped by these implementing partners, more especially White Ribbon Alliance, which went down. And when it went down, it collected the data, and they found out that the emergency obstetric care, it was not there. The basic obstetric neonatal and maternal care was not there. And they advocated for those equipment. And as I talk now, we have those equipments in our district. So you can see, there I was in a boat, because we have health facilities where you cannot reach with a vehicle. You have to use a motorcycle, which we call border borders in our country. You have either to use a bicycle or you use a canoe. Like that one, we were going for a health center, which is in the middle of, it is on the island, for support supervision. As time goes on, I think we shall continue discussing, but in order to improve quality care, we have to work together, and the government implementing partners, they provide what we need to use in maternity or in health facilities. Then we midwives, we have to be there because a midwife is an expert service provider while a mother is a service receiver, so that we work together as communities and government, opinion leaders, so that we give quality care. Thank you very much for listening to me.
Thank you very much, Feli. I always say the best obstetrics that I learned it from midwives, and here is a case in point. We are going to move on to our next speaker, who is Mary Ellen Stanton, who is a senior maternal health advisor for the USAID, and she guides the Global Health Bureau on maternal health portfolio, including research and implementation of country programs. Another seasoned midwife. Over to you, Mary Ellen.
Thank you very much. And I'd like to thank very much Dr. Ephraim, Your Excellencies, Professor Yifu Berhan, and Your Excellency, Mr. Talani, as well as all of the distinguished delegates that have come from countries here today. I think we need the slides. Next. I'm talking here today from the client's perspective. And while many women describe a satisfactory birth experience, we have a woman from Ghana who eloquently described her anguish in childbirth in a facility. In the hospital, they will be shouting on you, treating you like you are not a human being. Unfortunately, this is not common, but the sentiment is not rare either. Next. So what is mistreatment of women in childbirth? Well, it includes numerous things, including physical and verbal abuse. The slapping, the hitting is one thing. The verbal abuse, which might not seem so bad, actually represents to some women deep humiliation. There are other things that happen. It may not sound like a big deal not to follow the standards of care. For women, that can mean they don't get available pain relief that is available. They may not even get the choice to decide whether they go for surgery, for a cesarean section. This is not just an interpersonal problem. There are failures of the health system. Let's just consider this young woman who's in the photo. We don't know for sure everything about her. We do know she's covered up. She's now alone. Maybe someone left her after speaking kindly to her, telling her what was going to happen next, and going to find a companion of choice to sit with her. But maybe she's been there for a couple hours and not helped at all. Next. I found in some newspapers some egregious examples of abuse. The abuse we're talking about, although it may be, is not always subtle. The mothers who signed for stillbirth in advance were illiterate, poor women who actually had their babies stolen. The headline that talks about the woman chained to a urinal pipe, she was there because they were extorting money from her for her care. I hear stories about this over and over again. What changes the amount of time? What changes is whether they're holding the mother or holding the newborn. Next. Deplorable conditions are not respectful. Now, of course, not every woman is subject to admitted to a hospital where the mattress is rotting. Not every woman has a goat keeping her company under the side of the bed. However, I will tell you it is not uncommon for 2 women to share a bed, or 3. I thought that was as high as it went. My colleague tells me she has seen 5 women occupying the same space in a single cot. And of course, they are also sharing each other's body fluids. It's not just space. Women are expected to relieve themselves in an unworking or disgusting toilet. Personnel are sometimes absent, and life-saving commodities may be off the shelf. The women next who are most vulnerable, not surprisingly, next please, are the poor and the groups of people who are stigmatized. Now, the next slide, we want to know how common this problem is. I think if it to happen once is terrible, but there are studies that have been done recently in Kenya and Tanzania. More studies are coming out from many places. I want to say how courageous the governments and the organizations and the people were in Kenya and Tanzania to take on these studies. They found incidents of abuse at 20 and 19% respectively. They determined that this is a common phenomenon. Now, how should we think about this? Is it only 1 in 5, or is it a shocking 1 in 5? I would say the latter. Next slide. Why does this matter? I've got 4 reasons why this matters. I think if you only take the first one, it is enough. It is a violation of women's human rights. But also, women are less likely to come for care. Those who come for care are less likely to get prompt, life-saving treatment. And we have found in a study that women who were treated poorly in childbirth are less likely to go for postnatal care and even to take their children for immunization. This matters greatly. Next slide. Can anything be done? Absolutely. And again, I look to Kenya and Tanzania, who documented the problem, owned the problem, gathered stakeholders together from communities, from healthcare facilities and policymakers, and they got substantial and significant reduction in disrespect and abuse in a relatively short period of time. It can be done. Next slide. Looking to the future, we see a future where we eliminate the invisible wounds of obstetric violence, and we enhance dignity, respect, and compassion for all women during childbirth. I think we need to extend this to compassion and respect for women seeking family planning and for their newborns and for children. We're not looking for villains here. We are looking for fabulous frontline providers, the midwives, the doctors who are kind to women, and to champions everywhere in the policymaking arena and in the facilities to ensure that women have excellent quality of care as a matter of quality of care and of human rights. Thank you.
Thank you very much, Mary Ellen. If I was to ask you, if it was your daughter, your sister, your wife going to deliver in those places where they are disrespected, where the facilities are not clean, where would I have anyone raise their hands to show me who would want their daughter to deliver there? Can I see a hand, please? So we all want good quality, right? Is that right? We all want good quality for our own selves. But the people who are seated in front here, You have a role as our ministers of health, as our leaders, to ensure that those dedicated midwives who want to do their job right have the facilities and the equipment, but that those health workers also treat each other right. We are going to go to a movie for a while, a few seconds. We are going to watch a video on saving mothers and giving life in Zambia. Video, please. Video. Technology. Please don't let us down. Otherwise, I'll ask the honorable speaker from Zambia to start dancing until the video comes. While the video is coming up, I'll give you a life experience of when I was a first-time mother and I was in labor and they told me you are going to be referred to the referral hospital. The baby came very quickly because I was scared of going to the referral hospital. I had heard many good stories around what they did with you at the referral hospital. So even my labor was facilitated because of fear. So I'm hoping that that won't happen to my own daughter when she's giving birth. Video. Where are you? I don't have any other story, so please, quickly. Let's get that video. No luck? Right, if the video is not coming immediately, I can move over to the next speaker. Oh, the technical assistance is running pretty fast. Thank you. To the organizers, as you can see, we have a lapse, so you'll give us extra time for me and my panel, right? You are going to be very kind to us. We are going to get extra time.
Lelo bushukuru sumasana kwa mundubi. Uyu ni Teresa, aleya kunganda ya mufyala wakwe Mwansa. Teresa na ishwokutila Mwansa aline efumo. Muntambisha esu, banyina senge balapala umwana senge nga aline efumo. Nechi chila chitika mubumfiso ololibe abantu tabalati babuke. Ifumo te chintu icho abantu basansamuka. Bana mayo abengi balafwa na mafumo. Abana abengi nabo balafwa. Ishina lyandi nebo exiuda chola chate. Ninebo smag. Bali mfundisha ukubomba mu community ukusambirisha abana mayo pamona abana babo. Lelo ndeta ndalila mumushi Ruthi uli nefumo imieshi 80.
Ishina lyanje nine Ruthi Mushinge nalikuwa tefumo lili na 8 months. Ero lya number 2.
Natampile ukukumana na Ruthi ilio ifumo lyali ili nono. Ndemu ipusha ifyo wale umfwa n'obushikubwa kupapa ifyo bukaba.
Bana mayo bamo bachetekela bani na senge na bambuya wabo ilio baline efumo ilio bamona ati pali uwafya. Apano mbana adisambirira ekikankala kyakuya kwanti nendo mukupimwa. Apana adisambirira ilio lipabukulunga wakwata amadenja signs ufile wabutukira kuchipatala. Basimagi balatusambirisha ukudya efyakulya efisuma n'okubomvya mosquito nets n'okukana akwata malaria. Basimagi balatukoseresha ukwata amano yakusunga endalama mayanda libe nshita yakupapata irafika okuya ku hospital.
chaliba ichashupa bana mayo bambi ukuya mukupapila kuchipatala. Bana mayo bambi balafuma munchende ishtali. Bana mayo nomba balishba ukukankala bwakuya kuchipatala nga balinefu.
Bantu liba kushira babasimagi ifingi takwalebo ukutukoseleshako kaita bale tusambilisha ifingi panta twale kwato mte wakuya kuchipatala fwe balebera katali. So basimagi pali ino nshita bala tutandalira kumayande nshita no kutusambilisha obusuma bwaba kuchipatala.
Dilida uwa kulenga abantu imyewo kuya panta nshinaba natabalefwa na banyina abo tabalefwa nde batungirira nde basambilisha bwino ndabo wansansa sana pantu nshinaishwa kutila imilimo ya simagi ile bombwa bwino.
Thank you very much, Zambia. We are going to proceed straight away to ask Dr. Angel Mwiche, who is the Assistant Director of Maternal Health in the Ministry of Health in Zambia, who has worked both at the district and the teaching hospital level. And the question we are going to ask you, Dr. Mwiche, is looking at this, saving lives and saving mothers and giving life has seen incredible success in reducing maternal and newborn mortality. Now, how do you help to get the women to the facility? And when they arrive, how do you ensure that we in the health system don't let them down? Can we hear your experience seated from where you are, please?
Thank you very much, moderator. And thank you for showing the clip. It has made my work much easier. How I work, how we do it, how we did it, and how we are going to proceed doing it, focused and is going to focus on the already identified areas that contribute to maternal and child poor outcomes. And this relates to the first delay, the second delay, and the third delay. The first delay, largely, it is influenced by social, economic determinants of health. And you will have three broad categories around there. You will have personal health practices, societal level arrangements, and physical arrangements. Personal practices, we know what we do, how we see health, what we do to prevent disease, and health-seeking behavior in general. Societal arrangements is quite broad and wide. It has demographic arrangements, which may be sparse, may be congested, and you may need to deliver your services according to demographic arrangements that are available in that particular society. Secondly, on the societal arrangements, you may have issues of socio-economics that has a big impact. You may have education, you may have socio-cultural beliefs and religious beliefs. In the physical area, you may have a lot of challenges, and what you have mainly is housing, you have water and sanitation, you have climate change. And how we worked partly is to address some of the societal effects as well as personal arrangements. Looking at the amount of resource that you have, you may not be able to do or address all the determinants that affect social determinants of health. So we did try to engage the traditional leaders, we did try to engage the religious leaders, we did try to engage the political leaders. We identified people within those communities who could identify with those communities and be able to act as conveyors of information and as well as agents for change in terms of healthcare itself. In the area of delay number 2, which is usually influenced by geographical disposition, as well as socio-economic factors, mainly related to transport and communication. Again, what we had to look at was how do these women get to facilities? So we did try to bring in things that could help them move from wherever we could get them, either from the facility or at any point to the, either from the community to the facility. So we did procure transport in terms of motorbikes, bicycles, as well as ambulances. But as you saw from the clip, the transport that you acquire cannot operate in all those areas. So the other component of it was to strengthen community health systems to ensure that even at community level, they have means of transport that could get to a point where they could be transported to facilities.
Can I move you forward a bit? The third delay is the one where the health system is blamed. This woman has struggled to arrive in a health facility, then we let her down. What did Zambia do on the
So in the third delay, our focus was around the 7 pillars of healthcare. And we know that the 7 pillars of healthcare include, first, the service delivery itself. It has human resource. It has a supply chain. It has a finance component, infrastructure, leadership and governance, and health information system. Key, and according to the resources that we had, we did address most of them. We did address the issue of human resource. We employed people in facilities that could deliver services when women get there. But not only employing them, we ensured that they had the skills to deliver the services. So they underwent training as well. We ensured that the infrastructure was appropriate for women to come. We procured beds, linen, equipment for services to be delivered. And of course, strengthening leadership itself and ensuring that health information was up to scratch, ensuring that we keep the record and we are able to use this record to deliver the services appropriately to the women.
Thank you very much, Dr. Mwiche. I'm going to move on now to Pompey Sridhar, who is the India Director for Make for Mothers. Pompey is a strong advocate for using market-based approaches to tackle social challenges, and she has decades of working in the healthcare and financing in India. Now, the question I'm going to ask you, Pompey, when you are working in the private sector, and those of us who are in the public sector, we always have this kind of tiff, because if the private sector is unregulated, we don't know how you can contribute to improving quality of care. Can you just share some of your experience? And while you are there, just talk about the role of professional associations, because we see them more in the public sector. Do you feel them at all in the private sector? Over to you.
Very good afternoon, organizers and distinguished delegates. Firstly, I'm very thankful for the opportunity to share our views and also the private sector views at this forum with this August gathering. The number of mothers that die every day is simply mind-boggling. 800 mothers, which is like 2 jumbo jets crashing every day, full of mothers, shattering that many families, leaving behind some children who suffer for years. This was therefore something that we kind of wondered, was it something that business could solve? Was it something that the private sector should adopt? Because till date, maternal mortality as a challenge has been adopted by the public sector, and numerous initiatives have been taken by the public sector to address this, and progress had been made. But in 2012, we looked at whether we could use our scientific and business expertise to come together with the public sector, the donor and the development community, to solve this issue. And why the private sector? Despite the public sector improving in most of the countries, we still have a large number of women who go to the private sector. In Uganda, in the bottom quintiles, it's about 40%. In India, it's somewhere between 70 to 80% who go to the private sector. Not just because the public sector is not there At times, it is because health is an aspirational value. You want to have a baby, you want to spend a lot of your savings to have a really good experience. And that's why people end at the private sector. And we also know it's very difficult to regulate the private sector, especially in countries like India, where I come from. Despite there being so much of competition, despite there being so much of trained manpower in pockets, it is a struggle to assure quality within the private sector. So what did we do? So we adopted quality of care as one of the key pillars of our work in India, along with consumer empowerment. So on one hand, we are working on improving quality with the private sector hospitals, also trying to link them with the public sector. Why should we link them? Because not every case can be solved at a private sector. Some cases go into complications. They will end up going into a public sector hospital. So can we have these linkages strong enough so when the case goes to the public hospital, goes with a digital record or with a case sheet so that the patient is attended to and is treated at that very moment? So looking at this whole entire ecosystem, we started to work along several models. One of them was social franchising. The others were around, this whole consumer empowerment. So actually developed something like a TripAdvisor, an online platform in which the consumers can go and give feedback about a particular, about a particular facility. And all of this had an impact on benchmarking quality in the private sector, in kind of improving quality in the private sector itself. Some of the other initiatives that we have worked on is accreditation, because we believe that to ensure that improved quality lasts and sustains, one has to get into some kind of an accreditation. So we first worked with set of providers through our programs, and once the quality is improved, we are coming up with a quality assurance system, whereby there is a certification system which becomes an entry point to an accreditation system, which is independently done by the national accreditation body. And hence, we are trying to ensure that when we move out, when we exit this place, this whole quality system will be there to stay. And in this whole process, we realized the importance of the professional association, like the Federation of Obstetrics and Gynecology Society. So we figured out that this association had a unified voice, could represent the private sector, could negotiate and actually get work done, handhold them for the skilling and the capacity building that was required for this whole quality journey. And we therefore said that in the next phase, from the simple programming and working on quality improvement, can we institutionalize this particular professional body to carry on this quality improvement through a national quality management unit, which is focused only on the private sector. And an independent certification and accreditation supports this whole process for a lasting quality assurance.
Sorry, I have to rush you a bit.
So, essentially, we do believe that as private sector, we still need to challenge ourselves as to how do we solve these challenges that we are coming up with, every now and then there are newer challenges that we're facing. So as private sector, we're willing to fall and learn, to address these challenges from time to time, and come up with more innovative solutions.
Okay. Thank you. Thank you very much, Pompey. I'm going to move now to Mokhtar Ahmed, who is the General Electric Healthcare. He is a biomedical engineer by profession. And the question that I'll ask you, Mokhtar, is in many health facilities, providers are limited in their ability to provide care by the resources that are available to them. What power do new technologies have to improve what health providers can give? Over to you. Please, can you switch off the other microphone, please?
The other one?
Yeah, no. Please, can you switch off? Yeah, Mokhtar.
All right. So thanks, moderator, for the question. I think from my colleagues, what they were saying about the issues we have in the health centers, the quality from the perspective of the client, from a midwife perspective, the whole ecosystem we need to look at. Like my colleague from Merck for Mothers said, technology can play a very good role on all of these things, and I'm going to that in a minute. But I need us to look at technology as an enabler, not a panacea. And I echo my colleague Pompey that we need to look at the whole health ecosystem. Technology is one component of that, but training and capacity building of healthcare workers is another component. Power solution is another one. Water solution, the availability of essential commodities, the availability of health information system. All of these components are very important to provide quality care to people. Going back to the question and the power of technology, technology provide the clinical support for the standardization of care through standardized workflows, reference images, guided scanning protocols, automated measurements. All of these things can be done by technology. Technology also expand the access of care and enable healthcare to be shifted to the primary level facility, and that will lead to early detection of pregnancy-related complications and other NCDs like cardiovascular diseases or cancer and so on. And that goes to the level of the community, to the level of the health center and the primary care level. The technology also supports the delivery of outcomes and help getting the right decision at the right time. And one other very important role can play your question to Dr. Moichi from Zambia. Technology can enable the mobilization of pregnant women to the health center. When a pregnant woman knows that there is the right and good technology in the health center, the healthcare worker in the health center is able to use that technology and provide the right diagnosis. I think that will help mobilizing women to the health center as well. But talking about technology, we need also to mention something very important, the design of that technology. We all have seen the images from Ghana, from Uganda, and from Zambia. And this is a tough environment and completely different than designing a technology for a tertiary hospital. So while we design a technology, we need to take care of the real needs of the patients and the healthcare workers on the ground. So we start from ground up. The second point is the simplicity and ease of use of that technology. The users of that technology are midwives or nurses or GPs who has access to this for the first time, and it needs to be easy to use. And of course, after the images we have seen, durability is key. Battery operation, portability, low power consumption, damage resistance, all of these factors are very important. And we cannot move actually with providing care and quality and technology if it is not affordable. So affordability is the fourth criteria we need to take in mind when we design such kind of technology. Thank you.
Thank you very much, Moksa. Now I'm going to move to Dr. Sodzi Teti, who is the Executive Director and Head of the African Region for Institute for Healthcare Improvement. And the question I'm going to ask you, Sodzi, is what is the provider's role in terms of client satisfaction? Should we even be bothered about client satisfaction? They have come to the hospital anyway.
Well,
Should we be bothered?
Thank you very much for the question. I think it's something that we have to be bothered about, because increasingly the clients are being put at the center of the care process. And without involving them, really, we would never get the outcomes that we're looking for. Perhaps I should start from looking at what the expectations of that client are. A pregnant woman who comes to the hospital wants to have a live baby. She certainly doesn't want to die. She wants to be treated with respect. She wants to be handled by professional health workers who are empathetic and are treating her with a lot of respect and are also friendly. So given that these are the expectations that the woman would come into the hospital with, what are some of the ways in which we can design a healthcare system that would meet some of those expectations? And I think the first thing that would come to mind would be at the leadership level. Because often when we talk about improving the quality of care and meeting the client's expectations, it's left at the level of the frontline staff. But if accountability is held at a very high level, then it really impacts even the manner in which resources may be allocated. Patients want to be handled with privacy and confidentiality. Sometimes that would mean that we make special provisions for them so that they can be treated in that environment that they expect. And that means leadership would have to be held accountable for some of those decisions. Increasingly in the work that we've supported countries like Liberia, Ministries of Health in Liberia, Ministries of Health in Ghana to do, where they are implementing national healthcare quality strategies. If you look at the governance structures that are coming along with it, there's a very deliberate effort to include patients on advisory councils, on quality improvement teams at the facility levels. The point being that if patients are involved at that level, when the initiative is being designed, you would have no option than to factor their interest into whatever the intervention is, so that it is not a matter of health professionals sitting down, coming up with an agenda, designing an intervention, and then foisting it on patients, but they are actually a part of the decision-making process. And in many places where we have tried this, I think it's been most helpful. Because increasingly, the patients are not being seen as visitors to the facilities. They are part, actually, of the care process. And maybe I would end by looking at an example from Ghana, where patients were involved on quality improvement teams, and in one particular district where skilled delivery rates were very low, and the traditional birth attendants in the communities were actually recording higher births than within the facilities. They use quality planning tools to do process analysis, diagnose what their failures were. And it became clear from the community representation on the teams that when they delivered in the communities, they were given warm porridge to drink. This never happened in the health facilities. And also in the communities, they have the option of either bending to have the baby and not being compelled always to lie on their backs. These were two very simple initiatives, but the point is that once the facility displayed humility, accepted these suggestions from the women, and began to provide hot porridge in the facilities, suddenly all the women started trooping to the facilities to have their babies, and skilled delivery rates just shot right up there. So they are simple ways, but they are innovative in their own extent, and these are ways in which we can really meet the client expectations.
Thank you. I'm now going to turn over to the floor. I need some reaction from the floor. Anyone wants to take the floor and tell us where have we gone wrong, or what can we do right in order to improve the quality that we are providing in our facilities? Anyone wishing to take the floor? I'm an employee of the Ministers of Health, so it would be difficult for me to put you on the spot. So I would kindly request that, if you have some burning issues that you want to add to this discourse, please do so. We have 5 minutes of inputs from the floor before we wind up. Yes, please. Please identify yourself before you speak. Technology.
Is it on now? You hear me?
Yes.
Okay, thank you very much. My name is Moses Dombo, and I'm the Chief of Party of the Advocacy for Better Health project implemented by PATH in Uganda. I think, very briefly, if we can identify or find ways of moving away from talk, we know. I think we saw from Ethiopia this morning, we have seen from India, countries which have made some real forward movement. They had to inject significant amounts of resources in this area. If our governments can allocate more money to this issue, a lot of the things we are complaining about or talking about can actually become history. That's my conviction. Thanks.
Thank you very much. Anyone else? Any of the ministers? I see some ministers around the room. Can I give you the chance? Yes, madam, from Liberia, Honorable.
Yeah, thank you very much for the opportunity. I don't know, but I think it appears that from the discussions we have had, we as the health workers have the key to ensuring improved maternal and child health. So I don't know what we are doing, whether we need to put more effort in supervising people who are taking care of these mothers and children, because the evidence shows that, if you improve the quality of care you are giving to these people, the uptake of the services automatically increases. So the key here lies in the hands of those who are providing the services. We need to, like my colleague said, move beyond talk, and start acting. Thank you.
Thank you, Ma. I will take two more, and then we will come back to the, yes, Mali, and then I'll come to you.
Ghana.
Oh, sorry. You are sitting behind Mali, sir. Oh, sorry. Oh, I had given Mali first, then I'll come to Ghana.
Okay.
Sorry.
Merci beaucoup. Je félicite en tout cas les présentateurs pour les résultats ou les expériences ici présentées, dont nous tirerons certainement des enseignements pour améliorer ce qu'on fait. Mais je voudrais dire que il est important qu'à partir de cette rencontre, que nous soyons conscients du fait qu'aujourd'hui, on a véritablement besoin de faire de la mise en œuvre. De faire de la mise en œuvre. Je pense que toutes les expériences que nous avons régulièrement partagées jusque-là, je ne pense pas que nous les avons mises en œuvre de façon optimale. Nous allons continuer à discuter, on revient parfois sur les mêmes choses, et certainement, il y a de la valeur ajoutée chaque fois qu'on se rencontre, ça c'est clair. Mais est-ce que ce que nous avons discuté jusque-là, sur les actions qui sont vraiment, qui font la différence, qui permettent d'impacter, ou en tout cas de faire bouger les indicateurs, les interventions essentielles, est-ce que l'ensemble des partenaires se sont mis à l'unisson pour accompagner les pays, et est-ce que les pays même se sont mis devant pour vraiment faire accomplir ça? Je pense qu'il y a besoin d'argent, mais ce n'est pas que de l'argent. Il faut d'abord qu'on puisse asseoir ça. Il y aura certainement besoin d'argent, mais tant qu'il n'y a pas ça, quelle que soit l'augmentation des ressources qu'on fera, je pense que la différence ne se fera pas voir. Je tenais vraiment à insister sur ça et dire que le fait de acting qu'on a mis devant doit amener chacun à réfléchir qu'il faut aller vers l'action. Je vous remercie.
Je vous remercie, Monsieur Ghana. And then last comment from there, and then we close. We come back to the panel.
Thank you very much. Sorry. Thank you very much. As I sit here, I felt embarrassed by the film that was shown earlier, that Ghanaian health workers disrespecting patients. But it is something that is not news to me. I believe that it goes a long way to also contribute to the challenges that we're having in the health sector. The difficulty, however, is that it is born out of lack of discipline. I don't know what happens in other countries, but in Ghana, it's like public servants, you cannot easily discipline them. But the same nurse who is sitting in a state institution disrespecting patients, he goes to the next door private facility and he behaves like an angel. So I feel that the time has come for those of us in authority to try to bring some discipline in the public sector in terms of the attitude of our staff towards patients. Thank you very much.
Thank you. One last comment over there. I'm very sorry. I know the interest now is increasing, but the time is also decreasing. So one last comment and then we wind up.
Thank you very much. I'm so much impressed about the issue of quality and maternal child health, but also it means quality in all our provision of healthcare in the facility. One thing that I think we need to point out, we have always taken quality improvement as a desk office in a ministry. It should be a directorate. Tanzania, I'm happy with having a directorate of quality and improvement. It's not something easy. You can't offer any good services without taking quality seriously. But also, another issue that came in, that I saw in India, that they said about stepwise approach. That's very important. We cannot today compete with the developed countries when they're still in the developing world. It's a stepwise approach. I need to put a lot of effort in that and resources. But there's one thing that we get confused in. When we go out as the Ministry of Health officials and we talk about our facilities and the private as their facilities, all of these are under the ministry. All of these are under the same ministry. And the supervisor is the same. And therefore, we should make sure that when we are bringing quality improvement programs in our countries, it should cover both sectors, public and private, because still our nationals, our people, will still be served in those facilities. And right now in Africa and other many countries, like even in India, up to 40 to 60% of people get their treatment from the privatized facilities. So let's not forget this as part and parcel of the health sector. And together with this, just to make sure that we can do this, it means that we need to allocate resources, and not only for the public, but also for improving the private sector in quality, to offer quality services. So we should do it together. It's a public-private partnership. Otherwise, part of the population who are served by the private sector will suffer. Thank you.
Okay, on behalf of the panelists, can you just allow me to summarize, because we are now completely out of time? I think what I heard from this room is less talk, more action. You, as our ministers of health, are our custodians of health. So if you say you are not aware of what is happening, supervision is not happening, discipline is not happening, as somebody has said, the same provider in the public sector is very rude. Find him in the private sector is very nice. The same human being. So it's possible to improve things. I think we still have enthusiastic health workers among us who want to deliver quality. Can you please facilitate them to do what they need to do? Of course, we have some bad apples that are rude to people. I think we need to do something about that. There are standards. WHO has quality standards against which you can measure whether you are making progress. And this is the work that needs to be done. That commitment that our colleague from Mali mentioned, with all the partners around the table, all of us supporting you to make sure that that happens. Health systems, any program that we are going to talk about, if the health system is broken, nothing is going to happen. So I think we have heard on we need to improve, we need to strengthen the health system. There was an issue about consumer empowerment. There is nothing for us without us. I think we have heard it among the adolescents. That's their mantra now. But we don't seem to be taking our consumers together when we are looking at health systems. So I think this is some of the things that have come up. Technology will help us, but it has to be technology that is appropriate. I would like to ask you to give a round of applause for my distinguished panel before we wind up. And thank you very much. As you go ahead, as you go home, please remember, let's not let those women down. They have made great effort to come into the health systems. When we let them down, we are chasing them away. They won't come back. Thank you very much. Have a good afternoon. Right. I hand over to Ephraim to take us to the next session. Thank you.
Very wonderful job. Thank you so much, Dr. Zawaira. Tomorrow you have a new MC. Well done. And we really thank the panelists for sharing us their ideas and their perspectives. You may depart the podium. Thank you so much. Please follow them with a round of applause. I think summarizing a session that's already summarized won't be appropriate. But one message resonates. Even though childbirth and maternity should have been a happy and a nice experience, there are several nightmares that they have been shared so far for us to take action on them. In Ethiopia, the way we call a pregnant mother, it's called nafsa tzur. It means life at stake. It means a life that is not certain whether it will survive or not. It is as severe as that. And there is an African saying that says, a pregnant woman is a woman that has one of her legs on ground and the other leg in the grave. So we need to change this thinking, and we need to change this reality, because it's actually a reflection of reality. We have seen that walking the talk is the main intent. And of course, something will be covered by the next panel, which is financing. all underpins down to the money that requires to invest on this area. Ladies and gentlemen, before we break to the next tea break and marketplace visits, which all of you will be part, I would like to iterate that for those of you maybe perhaps living in the tea break, that we have a state dinner today hosted by His Excellency, the Deputy Prime Minister of Ethiopia, at the Hilton Hotel starting from 6:30. I will re-announce this after the next session as well. Thank you so much. Now it's time for a tea break. Have a very good refreshment and mingling and socializing. Thank you so much. We need to return here at 15:45 or 3:45.
But not on, okay. Yes. No, I'm... It's a bit weird because the person, you have to tell her when she maybe it's like you have to do it several times. So I'm safer.
Calm down. Look at it. Andi तरफ. Andi जोर भाई माँ.
I should just do it because I know what she's talking about.
Sure, then she
and
doesn't
I'll
have to say
click
next.
because she won't understand the subject. It's not that she won't, but it's
No.
when she says a phrase, I know what's coming.
Instead of saying next, I hate that part, by the way. I agree with you. I know, I hate that. Okay, we're good. Yeah, no, let's do this. No problem. You are done. Yes, well, actually, one from my colleague Naomi. Yes.
نجمر السبسة وصل.
Tell them not to forget their card, and tell them if you have not received a card, there are plenty at the information desk. Please pictures at the information desk. And then they also said logistics will clear out and then Sirazu. Bus will take them back to their hotel, and then we'll pick them up from their hotel at 6:15, take them to the dinner, and then take them back to their hotel at the end of the dinner. Cool? That's what
For those
the
who are escorted, no.
for those who are staying at the event hotels.
Designated hotels.
Good?
Good. Very good. Thank you.
Yazga Bachona,
እንደዚህ የጎተቱ ካላመጣችሁ
ስፒከሮቹ they ready?
Please take your seats. Excellencies, heads of delegates, and ladies and gentlemen, please take your seats. Please take your seats as we are now about to begin the next session. Can you please tell everyone to come in? I know that there are a lot of people outside. Ladies and gentlemen, as the day goes by, and as the discussion gets hotter and hotter, and as few of our colleagues are calling up for action and stop the talk and start working out, and all this being in mind, whatever we have decided, whatever we commit to do in our countries, it can never be achieved without financing. It's all about the money. How much do we invest in maternal and child health? We know investing in mothers and children has a greater impact and also a return to the investment. $1 spent in maternal and child health is $8 in return with an economic development and growth. To reap such a great dividend, there is a need for a greater commitment in financing. I would like to see handouts from the House, especially from our delegations from different countries. How many of you do provide free services for mothers during maternity? Free services for mothers. I'm raising for Ethiopia, and my colleagues are also raising. Free services for mothers. Excellent. Free services for mothers and children as well, children under 5. All of us have understood that the fact that mothers cannot be separated from children. How many of us have we made the Abuja Declaration of 15% contribution? A champion, please, if there is one. I know some of the countries are closer, even though they have not really reached to the 15% mark. How many of our countries have insurance schemes in any different sizes, in any different pilots or scaled-up programs? Insurance schemes. There is already a promising progress. I think such a promising progress will need to be applauded for all the greater focus we made on mothers. In the morning, I think it requires an applause as well. Almost all countries provide free maternal and child health service. And many countries, considerable number of them, have started some form of insurance schemes. And we also understand every country is striving to reach and meet the Abuja Declaration 15% share of health expenditure to actually come from as part of the entire country's expenditure for health service. To reach the SDG targets, we need $33 billion. It is a big money with a lot of zeros next to the actual 33, 9 digits. But of course, much of it needs to come from governments, and it's mainly domestic financing. We also understand some 30% of mothers do not have access to services due to financial limitations. So there is a lot to do with this respect. The next panel, the very important part, the will to actually cement our commitment, is sustaining financing. We have highly distinguished panelists to speak on what needs to be done different in financing. And the moderator of this session is Kelly Saldana, Director of Office of Health Systems, USAID. Kelly Saldana is the Director of the Office of Health Systems, and her career has spanned public health and international development. She has supported a wide array of health systems, especially in Latin America, including Haiti earthquake response, and more recently leading USAID's Zika response as well. She's also served in a variety of roles within USAID, including Office of the Health of Infectious Disease and Nutrition, Maternal and Child Health Division. It's a very great pleasure to have you with us. You have the chair, please.
Thank you, honorable ministers and distinguished guests. Each year, worldwide, millions of infants are born, many with lung immaturity that leads to respiratory distress syndrome, a major cause of morbidity and mortality. Respiratory distress syndrome affects roughly 1 million neonates each year and is almost always fatal without effective treatment. Continuous positive airway pressure therapy, or CPAP, is the standard of care for treatment in much of the world, although that treatment's inaccessible to many of the hospitals and health facilities in the countries that you come from, because the machine is too expensive for many facilities to afford. USAID's Saving Lives at Birth partnership has identified a low-cost alternative known as the Bubble CPAP machine, which promises to make this machine much more widely available in many of the countries in which we work. Why do I highlight this example? One, I think it's a good example of the purpose of our efforts under Acting on the Call. We seek to identify innovations and new approaches that we can roll out that will help us accelerate progress on ending preventable child and maternal deaths. But I also think it helps to highlight the purpose of this year's report, which notes that it's not just about identifying these best practices. Countries must also identify and work to resolve critical health systems bottlenecks that impede the scale-up of new innovations and approaches. Health financing is one of those bottlenecks. Sometimes a low-cost solution is not enough to truly make a difference. To make innovation successful, countries must be able to take advantage of new frontiers in health financing. You've probably heard the first law of health economics, which states that as countries' GDP grows, total health expenditure also increases. That's a good thing, but it's also important to take a look at the makeup of that health expenditure within countries. This chart shows the 25 countries that are here today, based on whether or not their total income over the period from 1996 to 2011 stayed lower income, grew to lower middle income, or stayed lower middle income. Those who grew to lower middle income, you'll see, had a slight increase in government expenditure, which is a good thing, although this is not enough to make up for the loss in donor resources. And really that loss gets taken up, the additional spending gets taken up by out-of-pocket expenditures. Similarly, for those countries that stayed lower middle income, some of the funding from donors gets replaced by private sector financing, but it is still not enough to really reduce the burden that is placed on out-of-pocket costs. These out-of-pocket costs have real impacts on people's lives. Imagine the situation where you're forced to decide between caring for your newborn infant or supporting your family. This is the choice that many families have to make. If you choose the former, you risk backsliding your family, putting them into poverty, or reducing socioeconomic status. If you choose the latter, you risk the health and the life of your newborn. Think back to the bubble CPAP machine that I talked about. Although we're able to lower the cost of the machine, this isn't enough because hospitals still charge patients for the delivery of oxygen. In fact, recently, USAID in Nigeria was unable to enroll enough patients into a study of the bubble CPAP machine because we could not get patients to accept the cost that they would have to incur for oxygen. Putting a newborn on oxygen for 1 day, sorry, can you go back? Putting a newborn on oxygen for 1 day costs 130% of the monthly minimum wage in Nigeria. And this is a country where 61% of the population live on less than $1 a day. With out-of-pocket healthcare costs such as these in many countries, you can see why the burden of out-of-pocket expenditures is too immense and will greatly impact any progress we attempt to make to end preventable child and maternal deaths. Unfortunately, the financing bottleneck is not only apparent in these tough choices that poor families have to make regarding high out-of-pocket costs. Last week, the media reported that at a hospital in Gorakhpur, India, oxygen supply was discontinued to the hospital because there were issues with getting the payment to the provider and the supplier of the oxygen machine. This tragedy, per the media reports, resulted in numerous infant deaths, and it highlights the importance of focusing on system-wide financing issues. Our financing approach should seek to strengthen systems of payment and accounting at all levels so that critical life-saving resources such as oxygen aren't interrupted. We need a renewed focus on alternative financing models and a new way to think about financing for health so that key innovations such as the bubble CPAP can be made accessible not only to hospitals and health systems, but also to babies and their families. Donors' grant-based aid must begin to shift towards financing instruments which facilitate country-led transition to more sustainable health budgets and reserve grant-based aid for global public goods and the last mile. Domestic resource mobilization, or DRM, I think you have to click through to the next slide, sorry. Domestic resource mobilization, or DRM, is a viable solution to increase domestic investments in health for the population and allow them to rely less heavily on donor assistance. It includes activities such as tax reform, public financial management, and impact investing. It increases resources by creating space for and leveraging the private sector in the financing and delivery of services. It also increases health investments by supporting the generation of evidence and analytics for national budget advocacy, and it promotes and achieves greater technical efficiency through health system design and functioning. In short, DRM helps put a country on a long-term path towards sustainable financing for its development goals. It's a critical step on the path out of aid independence. Now I'm going to provide an example from USAID for each of these aspects of DRM. First, growing the pie. In Liberia, from 2011 to 2014, USAID's Economic Growth Bureau worked with the Liberian Revenue Authority to increase the collection of taxes. This resulted in a $54 return for every dollar invested. We also want to use DRM to grow the health sector slice of the pie. In Kenya and other countries, work to develop the capacity of county governments for health sector planning and budgeting through program-based budgeting has resulted in increased contributions at the county level. As of June of this year, more than 26 Kenyan counties have mobilized approximately $7 million of domestic resources back into their health accounts. Finally, we want to use domestic resources to get more out of each slice of the pie. Think back to the bubble CPAP. Innovations such as these and other approaches that we talk about at these Acting on a Call events are how we work to get more results from the same resources. But as I've talked about, it's not just enough to identify these approaches, we must address the financing bottlenecks. By 2030, Few of the countries here today will be able to cover the full package of essential services through government resources. Others will have significant resources within the country, if not through government resources. Regardless of these projections, all countries here today should begin thinking how to optimize and harness these resources so they can best be utilized to achieve an end to preventable child and maternal deaths. USAID will help this by promoting better dialogue between governments, bilateral and multilateral organizations about financing approaches that draw in a greater mix of sources of financial resources to reduce costs, improve access to patient-centric quality care, and provide sustainable solutions. We are committed to creating a high-impact financing to reduce dependence on external assistance, increase donor spending on health, foster market-based solutions, and improve efficiency and equity in the use of resources in our partner countries. Now, I'd like to introduce our next speaker, Dr. Angela Gishaga, CEO of the Financing Alliance for Health. Angela has been at the forefront of health service delivery in Kenya, as well as part of a multidisciplinary team offering superior quality services in resource-limited settings. In 2014, Dr. Gishaga was promoted to the role of health economist and the director of policy planning and healthcare financing unit within Kenya's Ministry of Health, and she joined the Financing Alliance for Health earlier this year.
Ladies and gentlemen, all protocol observed, good afternoon. Good afternoon. It's a pleasure to be here to represent not just the Financing Alliance for Health, but the multiple partner organizations that are members of the Financing Alliance for Health. If I could please get the presentation up. Thank you. I'm grateful for the opportunity to present some of the insights that we have developed with our friends and colleagues from Dalberg and with the support from the Center of Innovation, Accelerating Innovation and Impact, that focus on financing and identifying opportunities of better leveraging domestic financing, as well as crowding in new players within the sector. On the next slide, just to build on what Kelly had said, just looking at the picture of public health expenditure, we see that even though the per capita expenditure on health is increasing, if you look at the public expenditure on health, out of the total budget from domestic resources, it's significantly declining. This is work that was done by our colleagues at WHO. And this is a green picture to show. Declining domestic financing shows us that there is an opportunity for domestic resources to be mobilized within the health sector. On the next slide, if we take a community perspective, looking at community health as part of a larger primary healthcare approach, we see that there is insufficient funding for community health systems within the larger primary healthcare system. There's a $2 billion gap in the funding of community health systems. We've heard today from Dr. Ephraim and other speakers that there's a $33.3 billion gap in healthcare financing. For community health systems alone, we have a $2 billion gap. Currently, only 8% of the direct assistance to health using IHME data is being given to community health systems. And we actually need about 3 times that, about 22%, to build strong, sustainable community health systems. On the next slide, not only is there insufficient funding at the community level, the existent funding is significantly fragmented. What does this mean? The opportunity to build a strong horizontal platform from where we can offer several services is being missed because we are not being able to invest on an integrated system at the community level. On the next slide, we look we have seen that now the sources of funding are insufficient. But let's look a bit deeper. What does this actually mean? What does this actually mean for those who are seeking care? The out-of-pocket expenditure for different people who are seeking care is significantly high. Looking at different archetypes of country within sub-Saharan Africa, we can see here that irrespective of the type of country in sub-Saharan Africa, out-of-pocket expenditure is significantly high. In addition, we also see that there's significant dependence on development assistance for primary health care. Using a sustainability lens, what does this actually mean in terms of the burden of seeking health care, accessibility issues for patients who need health care? On the next slide, I want to emphasize that despite the current financing landscape that we are seeing, the case has never been stronger than it is today to continue to invest not only in primary healthcare, but healthcare at the community level. The economic case, the health case, as well as the wider societal benefits. In terms of the health case, we have had a significant number of deaths within the community are preventable, especially for the mothers and the children. Our team has already demonstrated that there's a 10-to-1 return on economic return on investment. For every dollar we invest in community health systems, we are able to reach $10 benefit in terms of not just employment, but in terms of the productivity of the lives that we save, as well as the insurance impact. In addition to that, we have also been able to demonstrate that for some particular services, there is higher value for money by implementing and delivering these services at a community level. That said, and to echo what has been spoken across different panels, there are wider societal benefits to community health systems. Benefits in terms of women's economic empowerment, benefits in terms of giving the community a true voice to take ownership of their health experience, and their health pathway. On the next slide, we just wanted to distill some of the lessons that we've learned from the countries that we are currently engaging. What are the lessons that we can learn in terms of political commitment around financing of health systems, as well as the role that we play here in this room? For political commitment, it's important and cannot be overemphasized that the political will and buy-in is important, not just at the top level, but across different levels in government as well as within the development partners. In addition to that, from the examples that we've seen in the countries that have successful community health system, ministerial coordination of the multiple stakeholders involved is extremely important. In terms of financing, beyond just political commitment from the governments, we require and see that there is value in having actual financial contribution to community health systems. This has been shown to not only signal the seriousness that the government gives to community health systems, but it also facilitates the crowding in of additional financing into the system. Moreover, we realize that we need to better utilize the current financing available domestically within a country. How can we make more effective and efficient use of the resources that we already have? And in addition to that, how do we also support the public sector in developing well-costed plans that can be able to attract private sector players who are interested in investing within the community health systems? Underpinning all this is the role of the development partners. How can we draw together? How can we work together? And I believe it has been spoken across different panels today. How can we work better together so that we can give the expertise to the public sector and guide them in making the right decisions in terms of getting the political buy-in as well as catalyzing additional financing. What does that mean? How do we guide the governments to understand how their increased investments can be plugged into the more sustainable parts of funding? And then we pull together as partners and help fund perhaps the startup costs, the high capital costs that may be required, and support the governments to think through how to support and plug in more money into the recurrent costs. On the next slide. As part of the Financing Alliance, we continue to support governments across sub-Saharan Africa, not just about thinking of building sustainable community health systems, but also pooling resources and figuring out how to build sustainably financed, resilient community health systems. We support governments across the community health financing pathway, all the way from strategy and policy development to understanding the financing pathway that is required to ensure that their community health systems are financed sustainably in the long term. We do this in a long-term relationship through some of the analytical tools that we have that support governments develop detailed, well-costed plans, as well as creating awareness around financing mechanisms and modalities that are available to them to better utilize the finances, and in leveraging opportunities like this, platforms like this, to advocate for increased funding within the primary healthcare systems, particularly at the community. We look forward to engaging with you and working together and doing what you have been asking us to do during this conference, in acting together to make sure that not only do we save women and children's lives, that the lives that we save, the children are able to survive, to thrive, and also transform the continent that we live in. Thank you very much.
Next, we'll hear from Dr. Hind Khatib Othman, Managing Director of Country Programs for the Gavi Vaccine Alliance. Hind Khatib Othman joined Gavi, the Vaccine Alliance, as Managing Director for Country Programs in 2012. She comes with a wealth of very relevant senior-level experience, having managed programs in countries and regions and working in multi-partner organizations at regional and global levels.
Thank you. Good afternoon. Honorable ministers, distinguished guests, and colleagues. I'm very pleased to be here with you today to speak to you about the Gavi model. The Gavi model, through its eligibility and sustainability policies, and see how through this policy we have been able to work with countries to create an environment for long-term sustainability. But before I do that, I want to acknowledge the critical role that the African leaders have played in improving maternal and child health. This year has been a very significant moment for immunization, where 54 African leaders in this very same room have actually committed and their support to the Addis Declaration on immunization, a declaration that demonstrates their commitment to ensuring universal access to immunization across the continent by allocating adequate resources for the cause, for the mission. I also want to congratulate a number of countries in Africa as well as Asia, as the WUNC latest data on immunization have shown a tremendous increase in coverage. In Africa, it went up to 81%, and in Asia, we have coverage over 90%. For me, then, moving on to Gavi's model, actually, I just want to briefly discuss how Gavi works. The slide shows in a nutshell our operating model. So the horizontal axis represents time in years, while the vertical axis represents the cost of vaccines. In Gavi's models, all countries, regardless of their level of wealth, pay a proportion of the vaccines they introduce with Gavi's support. This is what we call our co-financing policy. The level of co-financing obviously differs based on the GNI per capita. The poorest countries pay the least, and as the country's economies grow, then they become richer, then they're asked to pay a greater share of the price of vaccines. So if we, in the initial phase, self-financing, which is the green part here, comprises of countries with GNI per capita below $1,025 per year. Countries pay a very low, flat amount of US 20 cents, basically, per dose of any vaccine they introduce. Once countries cross that GNI per capita level of 1,025, they move in the preparatory phase to transition, which is the blue one here, where their contribution increased by 15% per year. As they become, also as the economy grows, their GNI per capita passes Gavi's current eligibility threshold, which is 1,580 US dollars. Then they enter a 5-year period during which annual co-financing requirements increase sequentially, so that at the end of the period, the cost of vaccines are fully paid by the country. And they are much more self-sustaining their immunization program. The next slide is just the grouping of countries that I spoke about. And you see the first grouping has the largest number of Gavi's eligible countries, and then they move on from one phase to the other. And obviously, as we learn, through our policies, we continue to develop and refine them over the years. And with every set of countries that transition Gavi, there is a new learning that come and our policies evolve. Next slide, please. This actually speaks positively for countries and their contribution. So over the years, if we start from 2008, as early as 2008, you will see the portion of the countries co-financing to the vaccines. And you'll see in 2016, the countries have contributed to vaccines $158 million. The co-financing policy has been actually quite successful in mobilizing significant resources for vaccines in countries. And we're hoping, and at least the learning, that it is contributing to long-term sustainability of immunization programs. So far, I mean, obviously, the increase over the years, I'm still on the previous one, the increase over the years is because also the number of vaccines introduced by countries have increased, and they have introduced actually more expensive vaccines such as PCV, Rota, and HPV. Moving on, obviously learning through doing is that overall the performance of countries that transit from Gavi, the coverage is quite high. However, there are a number of countries where the coverage is not as high as the expectation or as we'd like to see it, such as in PNG, in Congo Republic, in Nigeria, in Angola, and other countries. And if we look really there, and I think the main reason that we have learned is really related to the system's weaknesses. When we look at immunization financing, we don't really understand, or at least perceive, that it is a matter of a fiscal space. It's much more about prioritizing and where you put your budgets in. So we feel that most countries that have a struggle in continuing to finance their vaccine programs is that they're not doing adequate prioritization. They have weak planning, budgeting, and their disbursement processes in countries are not optimal. And then obviously the major gaps are in the systems, where health systems have not grown as the economy have grown. The human resources capacity is still weak, and they're not spread across the immunization programs and systems. Information systems are very weak, and thus data is not there. And then the cold chain is also weak and is not covering the whole country. We've learned also that institutional capacities make a big difference. And in countries where we don't have regulatory authorities that are functional, it becomes more difficult in the procurement of vaccines and in basically understanding the rules and the practices. Where there is a good functioning NITAG, for them to continue looking at the epidemiological data and continue to grow their vaccines, then we feel that sustainability has a bigger chance. Political commitment remains a key. And obviously, political commitment of leaders is critical for long-term sustainability. Moving on, so the important lessons actually is to prioritize and prioritize and prioritize, and make sure that your overall health budget has a big portion to the vaccines and immunization. When countries prioritize tertiary care, then primary health care gets less and less money. Obviously, there is no silver bullet, and that's why in Gavi we continue to customize our support based on a country context. But there is actually no substitute for the countries from appropriate planning, budgeting, and disbursement and execution. And we believe that sustainability really relies on two things. Finance is one, but the most important is to have the programmatic pieces in place. We believe early engagement and planning, making sure that we widen our base of negotiations, making sure that actually the ministers of health link early on with the ministers of finance, and together commit to the mission and to the cause is very important for long-term sustainability. These are so far the lessons learned from our eligibility and co-financing and sustainability policy. Our board continues to look at this very favorably, making sure that we continue to support countries and customize as to countries and adapt our policy and support to the country's need. I thank you very much.
Thank you. Now we're going to turn the conversation to our two country representatives because, as I'm sure you can imagine, trying to raise domestic resources for health, figure out how to fund primary health care and community health systems, and at the same time start to prepare for transition for your vaccine program is not an easy task. So I'd like to welcome, I'm going to introduce both of them and then I will ask a few questions. But I'd like to welcome first the Honorable Umi Mwalimu, Minister of Health from Tanzania. Umi Mwalimu has been Minister of Health, Community Development, Gender, Seniors, and Children in the Cabinet of Tanzania since 2015. She's a two-term Member of Parliament appointed to a seat reserved for women. Welcome. And next, I note there's a change on your agenda. The Honorable Minister from Nigeria was called to a meeting with the President at the last minute. We are very happy to have Dr. Emmanuel Mariboli here. He is the head of Monitoring and Evaluation Unit in the Nigerian Federal Ministry of Health. He's a medical doctor, and he is also Secretary of the Basic Health Care Provision Fund in Nigeria. So welcome. Okay, the first question I'd like to ask is for the Honorable Minister Mwalimu. Over the past few years, donor assistance for health has stagnated, yet we know that the population demand for health services continues to increase. Can you talk about what strategies are you using to increase domestic financing from health and what sources you find that financing in?
Thank you very much, Kelly. Honorable Ministers, heads of delegations, let me begin by saying that I feel very much honored to be part of this summit. The theme, overcoming critical barriers for maternal and child survival, confirms our commitment to improve quality of services for pregnant women as well as children. And before responding to your question, what is happening in Tanzania in terms of increasing domestic allocation for health, allow me just to give one overview, the structure of health financing in Tanzania. The government funding is about 30%, and development partners support is 36% support through Health Sector Basket Fund, Global Fund for HIV/AIDS, TB and Malaria, Gavi, GFF, result-based financing, and non-governmental organization. And health insurance covers about 9%. It is only 30% of the population which have enrolled in the National Insurance Scheme. And out of pocket is about 26%, of course beyond WHO recommended 20%. And the private sector is also contributing to the health sector financing. So just the present overview at least give us a picture that we have challenges in relation to sustainability, over-reliance on development partners, donors, also lack of effective financial risk protection for the poor, because 26% still pay out of pocket. So what is happening? What are we doing in Tanzania? Currently, over the last 2 years, we have been working to improve efficiency of current funding, but also we are working to reduce fragmentation of available financing insurance strategies. And our vision is to move towards the establishment of a single national health insurance scheme that also supports a minimum package of essential services. As I have already stated, we have 2 forms of insurance scheme, mandatory for the public service and compulsory for, voluntary for communities through Community Health Insurance Fund. So what we are working right now, we want to combine existing prepayment risk pool in order to have a single national insurance scheme. Last week, we are basically in the final stage of coming up with a legislation whereby we want to make health insurance mandatory to every Tanzania. A key challenge has been, of course, the debate between my ministry and Ministry of Finance. Who is going to pay for the poor? The government is paying right now for the poor. So, but because we are going to require every citizen to have an insurance, so it means the government also has to allocate money to pay to buy insurance card for the poor. Maybe another strategy which we are using to, as I said, to improve effectiveness of available resources, we are also implementing approaches such as result-based financing, especially for prioritized maternal and child health services that are evidence-based. In 2015, with support from partners, especially World Bank, GFF, we have undertaken an assessment of the quality of services, clinical quality, as well as management components of healthcare services in Tanzania. We call it a star rating assessment. And what came out from that assessment, about 50% of primary health care facilities were in bad condition. So we sit down with partners and then we discuss the way forward. We agreed now to introduce what we call result-based financing, whereby is a service delivery performance-based incentive scheme, and it is being implemented in 7 regions. So we provide money. It is not too much money, but within a very short period of time, we have seen services improved in those particular facilities, which were rated 0 star. They are now 2 up to 3 stars. So through what I can say, maybe because time is not on my side, through result-based mechanism, we are now able to track results and ensure better accountability. We, as I have started, we have undertaken a reassessment of those facilities which were assessed in 2015. We have seen a very, very big improvement in terms of provision of services. So I just want maybe to say, if we focus on performance-based incentive, we'll be able to improve also quality of services for the women and children in our countries. Thank you.
Thank you. That was very interesting. I think one of the things that we're starting to see is that the health systems topics and the themes of this summit, they all tie together. The previous panel talked about some of the challenges to quality of care, and you've just very nicely talked about the financing angle to that and how financing can help improve the quality of care and overcome some of those barriers. Now I'd like to ask a question of Dr. Mary Boulay. What do you think is the appropriate role for government in financing health services for the country's population? What role should the government play? What role should the private sector play?
Yeah, thank you very much. Let me first of all extend the greetings of my Honorable Minister. He would have been here, but for last-minute official call, he had to go back. So I'm just standing in for him. However, with regards to the question, if you looked at what has been presented, certain basic facts are in all our countries. Now, we are talking about decreasing health budgets. And besides that, we're also talking about what they call recession from one country to the other. We are talking about increasing out-of-pocket expenditure. In Nigeria, that's about 70% as at 2014. We're also talking about efficient use of the resources. We're also talking about the issue of co-financing. I mean, when development partners give us something like for immunization, which is important. We're also talking about coordination of the funding and investment in areas that are high yielding, such as primary health care. In all this, I can say the government's role is well spelled out. Government is supposed to provide for its citizens, both in making healthcare affordable and accessible to its citizens. However, because of the dwindling resources, you need to prioritize. And how do we prioritize in Nigeria? First and foremost, there's continuous engagement with the Federal Ministry of Finance, Federal Ministry of Budget and National Planning to ensure that we have increased budgetary allocation to health. But more importantly, government is also trying to ensure that we have sustainability of finance or funds coming to the health sector. In 2014, we had a National Health Act passed into law. And that act made the provision for what we call Basic Healthcare Provision Fund that is supposed to be derived from what we call Consolidated Revenue Funding of the Federation. In other words, before you start talking about budget, 1% of it, not less than 1% of it, should be allocated to the health sector. Then other sources are from development partners and other innovative financing mechanisms such as VAT, issues of even communication. When you make a telephone call, you pay for it. But these are things that were in the law that was passed. However, translating this law into enforcement is the issue. And government is talking with both our development partners and the legislature to ensure that we implement this law come September, October this year. In that vein, we've been talking with Global Financing Facility to help us with funds to operationalize this in 3 pilot states. So things are at advanced stage to ensure that this is done. Besides that, government is also moving on with coordination of all the different sources of funds for the health sector. More importantly is the issue of performance-based financing. We have the Saving 1 Million Lives initiative. We have the Nigerian State Health Investment Project, where we base our financing on output instead of input-based, and it's helping also. It is also trying to review the laws of National Health Insurance Scheme, which hitherto has been voluntary instead of mandatory. So it has gone through the second reading in the legislature, and we hope by the time we do this, there will be sustainable financing for health. Again, we are concentrating on primary health care facilities. Government is revitalizing 1,000 primary health care, 10,000 primary health care facilities within the span of government, which is 4 years. We have started, and we are collaborating with private sector partners. Let me conclude by saying that the issue is prioritizing healthcare, and the women and children are the most important. And for us to do this as government, we must ensure that we do the things that are high yielding. And the only way we can do that is even in our pilot programs, let's introduce what we call impact evaluation. Because that's the only thing that will tell you what is working and what is not working. And in so doing, you can also learn lessons and try to accommodate whatever you do. Again, national health accounts are very important in the African continent, particularly Nigeria. It will help us allocate resources to wherever is needed most. Because we might be talking about, oh, we are using money for something. Are we using it efficiently? Is it yielding the right resources? Is it yielding the right results? These are many others government will do to ensure that we have sustainable financing. So to cap it all, let me just say that intersectoral collaboration is very important. As Ministry of Health, we need to talk to our counterparts in budget and finance. Again, we need to talk to our legislators to ensure that more money comes to health. But let's put our house in order too by making sure that the little money we have, we'll use efficiently. Thank you.
Thank you. I think that was a very good example of several different prongs that you're taking to address the financing issue on several different fronts. I think both of our honorable representatives have talked about working with the Global Financing Facility, talking about performance-based financing incentives, and addressing the burden of out-of-pocket expenditures, and really I think some amazing activities that are happening in each of those countries. I wonder if each of you might take the other side to that story and talk about what are some of the biggest challenges to health financing, and what are the things that you're struggling with within the country or within the financing sphere on a day-to-day basis. Honorable Minister, would you like to go first?
Thank you very much, Kelly. First of all, let me say that the government of Tanzania, like many other governments in developing countries, are striving to ensure that people get high quality of healthcare services, of course, that are affordable cost, regardless of their economic status. But we have actually, this is what has been stated in our policy document and strategies, but the reality in the ground is quite different. So for what we are doing right now, even if we'll be able to get resources by 100%, we won't be able to deliver for high quality health care because of the challenges. For example, in my country, population growth 2.7% per annum, high fertility rate 5.3%, adolescent pregnancy is at 27%. So there are too many challenges. So I go back to the same issue which we have already highlighted. We have limited resources, but with limited resources, we have to make sure that whatever we have to utilize them effectively. For example, in Tanzania, with the support which we have been getting from the government and development partners, we used to disburse to the local government authorities. And then they don't disburse directly to the facility. It can take up to 3 months, 2 months. So what we have decided also to do in collaboration with development partners, we have also introduced something we call direct facility financing. So from this particular financial year, July 2017, we are disbursed directly to the facilities. So every healthcare facility, including a dispensary, they have already established a facility accountability reporting system. So we believe we will be able also to ensure timely availability of resources at the facility level, but also to respond to local priorities. I was listening, my lady from my sister from Uganda, the nurse, I think your midwifery, she was talking about you go to a facility, there is no BP machine. Same for Tanzania. You go to a health facility, there is no BP machine. Even women are not even screened for protein or for blood, whatever. So, and then the money is sitting at the local government authority account. So right now, we are disbursing directly to the facility in order to ensure that our people get high quality services. Thank you.
Yes, what are the challenges to health financing? The major challenge is political will. If we need to ensure that our people are covered for the health services they obtain, government has to be ready to pay for it. Because the truth of the matter is, if you look at the minimum wage, how much is it? There's high unemployment in Africa, there's also high unemployment in Nigeria. So for you to really finance healthcare, government has to invest in it. The second thing is we need to also change their thinking pattern. People look at health as a social service. So let's make an investment case for health. We have had, for $1 you spend on procuring vaccine, you are having a yield of about 100%, that's $10. And that's something we need to look at. Again, for health financing, we also have issues with our socio-cultural practices. In Africa, we don't think we should keep aside something insured for our health because we think we're inviting diseases. So let's change that thinking, that orientation of Africans, and start doing what we call community health insurance schemes, so that when somebody is sick or a pregnant woman wants to go to a health facility, he or she can be taken care of adequately. Again, let's also look at the wider picture, the economic recession, because health is what we agree, but then you need a healthy economy to also have a healthy workforce. So the other way around is, let's improve our economy so that it will positively impact on health. And with all this in mind, we should also think about accountability in our health systems. Please, let's invest in data. Let's invest in accountability systems so that the little money we are given, let's be sure that it's working for the system. So all I've tried to say is that the barriers to health financing in Nigeria lies with us as government. It also lies with us as people. It also lies with us as development partners, because most times, most development partners will be doing things in a vertical way instead of pulling resources together. And again, when you want to coordinate them, there's usually a lot of resistance. We all signed onto the International Health Partnership Plus and also signed onto the AIDS effectiveness agreements. That means you should align all your financing to the national strategic plans of the country and the national policies. So if we align all our expenditures according to our policies and plans, we'll ensure that the mothers and children, which are priorities, will be well covered. Thank you very much.
Thank you. I'm going to ask one more question, and then maybe I will let everyone provide some closing remarks if they're interested. We talked a little bit about how financing relates to quality of care that we heard in the last session, and thinking back to the session before that on equity and financial protection, when out-of-pocket expenditures is such a heavy burden on our finances, it becomes really something that can throw families into poverty or can reduce their socioeconomic status. And so looking to how we can use financing to protect populations, how we can direct financing to reach the populations that need it most. I was wondering if you have thoughts on or examples from your countries of what you have done to try and target financing towards the poorest of the poor or otherwise excluded populations. Dr. Mary Balawe, would you like to go first?
Yes, in Nigeria, one of the things we have looked at is that if you look at the lowest quintile of the wealth spectrum, they suffer most from issues of maternal and child health. And with the Basic Healthcare Provision Fund, we agreed to target the rural people and also make sure we target antenatal care services, deliveries, as well as immunization, including treatment for malaria for the under 5. But also more importantly, with respect to quality of care, there are certain indicators like you accredit facilities that will be part of providing the services. And you also cost the services that they are providing by costing the marginal cost, because government is already taking care of payment of salaries. So those marginal costs will now be paid through provider payment mechanism by government taking it over. So in so doing, we believe that people will go for health services when they need it, and we will also monitor to ensure that quality of services are at the right par before paying. In that case, we are tying financing and improvement in quality of care together. So if you provide services and it's not of the right quality, there are ways of knowing. And this we do with independent verification agents. We have tried it in the National State Health Investment Project, which is a kind of performance-based financing program we started in 2012 in Nigeria. And we are scaling up to under 5 states, which will cover almost 19 million people. This will tell you that it's working, and we hope with the Basic Healthcare Provision Fund, we are going that same way. And by so doing, quality and financing will go hand in hand, and we'll be better off for it. Thank you.
Yeah, thank you very much, Kelly. I think we are not very far from what is happening in Nigeria, especially in relation to mechanism we have put in place to protect the household from high out-of-pocket. Right now, we have the exemption policy for pregnant women under 5 and elderly. But we have also introduced, as I have already highlighted, the community health insurance system. It is not too much, but what we have realized, people are willing to enroll in community health insurance, but when they have the CHF card, when they go to a health facility, they are told no medicine, no services. So many people didn't find any incentive to enroll with community health insurance schemes. So right now we are working in improving especially availability of commodities in our facilities, especially we have allocated quite a big amount of money from the national budget. Our budget for medical commodities was, last year was 31 billion T shilling. Right now is 51 billion T shilling. So we came from 31 billion T shilling to 251 billion T shilling. So at least when you go to health facilities, especially at the primary health care level, there are medicine and people are willing to enroll with community health insurance schemes. And what also we need to do, what I have realized, people are not that poor. Yes, they are poor, but they are not that poor. For example, they can buy a voucher of 500 shilling every day. Per month is 15,000 T shilling. So we need also to sensitize them to make them understand the importance of investing in their medical care services. Because if you can pay 500 T shilling per day, it is 15,000 T shilling per month. And then a CHF card is only 10,000 T shilling. So if people can be sensitized and then can understand the importance of prepayment scheme, I'm sure I'll be able also to enroll many people be able to how can I put it, to assure affordability of services by the poor. But as I have already highlighted with the single health insurance, and since we are going to make it mandatory to all Tanzanians, so it means also we have also to, the government has also to pay for these groups of people who are exempted. But just to conclude, yes, we will be having financing gap as far as health financing is concerned, especially in developing countries. Funds will not be enough. What is important, we need to prioritize. We need also to understand where do we get quick and evidence-based result, where we put money. And then it is possible, for example, in Tanzania, we are making quite a very big progress. Of course, in terms of MMR, we are quite a little bit behind. And that's why now our focus and my focus has been on maternal mortality, on maternal health and child health. Maybe just to, you were talking about political will. We have a new government right now in Tanzania, and our message has been we need to see results of whatever you are doing. This has been a message of my president, His Excellency Dr. John Pombe Magufuli. Even my message to the sector, we want to see results. Everybody has to deliver. Thank you very much.
Thank you. Now I'm going to just invite each speaker to provide us with any final thoughts on health financing or on the conversations we've had today. Perhaps we'll start with you, Dr. Khatib Othman. And we'll just go right down the line.
Thanks. Thanks. Actually, I've been very interested in the discussion from the Honorable Minister and Dr. Emmanuel. It's great. Everything that they said actually really aligns a lot to the policy that we've spoken about and basically the learning agenda. And you know, there is no silver bullet. It really has to be customized. And I think it requires concerted efforts from everyone. And political commitment is key, but you know, paying attention to the systems, human resources, your delivery strategies, and I think creating a culture of accountability is so important at all levels that will help us to sustain and make sure that we continue with the quality financing and making sure that the resources are used to their best. Probably one last thing is that as a response, because Dr. Emmanuel said that sitting from a country and trying to even harmonize and align donors becomes a challenge. And from where I sit as a financing organization, I say we welcome this very much. Because definitely we do not want to fragment the country's capacities. We want to be able to support your efforts, support how you address your own national planning and policies, and be able to work with you. And if you feel that, I think you have to really take us on and say, we've asked on this and you have not, and because I think it's only the country that will get us all to align and harmonize and build on each other's support and make sure that the money is gone to support the country's efforts and where they want to be. So thank you very much.
I thought I had already concluded, but allow me just to say that while we are talking about financing for the health sector in our countries, we need also, whatever we are doing, of course, within the health sector, we need also to take into account what is happening in the other sectors. For example, in Tanzania, we have public sector system strengthening, especially on improving public sector financing management. So it does also contribute in delivering for the health sector. So there is also a need of actors to work together within government and outside government, especially in improving availability, access and quality of maternal and newborn health services, including inter-ministerial collaboration. This is very, very important, especially for countries like Tanzania, whereby implementation of healthcare is done at the local government level, and the ministry of my ministry is responsible for policy formulation, coordination, and quality assurance. And so my message also, if we want really to improve health financing, we need also to work within this framework of the public sector system thinking. Thank you very much.
Well, thank you very much. Parting words. One, we all need to work together to deliver sustainable financing for health. Two, we need to make an investment case for health. Health is regarded as a social service, but we all know that it also has an investment side of it. The more important one is, no matter what we do in the health sector, we should also know we are part and parcel of the country. So our country has an economic growth recovery plan, and we make sure that health is part of that plan. And with everybody's hand on deck, we will try, we're working hard with accountability in mind, we'll improve sustainable financing for health, especially the priorities in health, which is reproductive, maternal, child and adolescent health plus nutrition. By so doing, we will be addressing the critical barriers to maternal and child health. Thank you very much.
Thank you. We've all committed to universal health coverage. We've all committed to doing our best to achieve the Sustainable Development Goals. This requires investment in health, in the health system, and the entire health system delivery system. So thinking about what is the value chain for health, who are the important players within the health space. The community health system and the community health workers are a critical component of the human resources for health agenda. We need to, there's a role for each player to play. There's a role for the government to play, not just in increasing domestic financing, but also engaging within the government across different line ministries, the Ministry of Finance, as well as other frontline social development ministries, to make this a priority. There's a role for us development partners to play, even within our own frameworks and regulatory restrictions. How can we continue to collaborate and work together and help to support governments in increasing investments into this very important role. There's also a role for the community to play, the community in terms of contributing and prioritizing health in terms of the way they use their household income, but as well as also being able to speak up and demand for quality services and to demand for an opportunity to have a voice in requesting the kind of support that they need at the community level. So it's a multi-sectoral and multi-stakeholder role, and we all have a role to play. Let us all do our best to play our roles, and we can actually achieve universal health coverage as well as the Sustainable Development Goals. Thank you.
Thank you. And so just to conclude this session, I really want to thank all of our panelists. I think this has been a really fabulous conversation. A couple of themes that I note that we touched upon is one, prioritization. We must prioritize the areas of health, prioritize the populations and the health services that we want to. Second is the multi-sectoriality. Health financing is not just for the health sector. It involves the Ministry of Finance. It involves overall public sector work. Domestic resource mobilization can be achieved in many different ways, but one of them is growing the overall resource pie in a country, which doesn't have to be specific to health. The third is just the link of how this links back to the reasons we're here for the Acting on the Call Summit, and that health financing does impact women and children's lives. It impacts our ability to provide quality of care. It impacts our ability to accelerate progress, as do the other bottlenecks that we're talking about today. So I just really want to thank everyone on the panel for bringing to light all of these issues so eloquently and with such great country examples, and thank everybody. And then with that, we'll conclude the session.
Thank you very much, distinguished speakers of this specific panel on financing. Thank you very much. It's been very stimulating, insightful, and very productive session. We thank you so much. Please, a round of applause until they leave. I think it's also worth mentioning when we talk about financing, along with what this distinguished panelist has already said. Health is also a victim of its success. The health sector has actually managed to gather different development partners to bring onto the podium. And our ministers of finance, it might not be the case for many, but it's also a case for a couple of and some of the countries that our ministers of finance actually think, no, health has development partners. Let's leave health and let's only invest on the other sectors. Is that not the case in many of us? Is it? Is that the case? And it really requires for all of us to negotiate with our ministers of finance. The greater news is that our ministers of finance are not really monsters. They really understand when you tell them, as long as you have said it perfectly. I spoke to one of the ministers of finance in another meeting, and I stated to him, if you spend $1 in maternal health, you will reap $8 to $10 in return. And he said, why is that our Ministry of Health colleague has never told me this? So some of it might actually come from a gap from understanding information, and the need for negotiation with our ministers of finance would be quite critical. And of course, I think the panelists has already said, the move from all of us is increase the pie. When you have ideas as a health sector that can enable to increase the pie, our ministers of finance really like it. Taxation, new ideas, innovative financing, such as airport taxations, surtax, syntax, everything else that you might mention that can increase the pie. And of course, always negotiate to get much from the pie for maternal and child health, and spend wisely. As long as we value for money, and we also need to value for many, money that can be spent for the benefit of others. I thank you so much all. Before we close, I just have final announcements to make. As I earlier mentioned, at 6:30 today evening, we will have a state dinner hosted by His Excellency Ato Dammaqe Makonnen, the Deputy Prime Minister of Ethiopia, and it will be at Hilton Hotel. The shuttle that will take you right after from this meeting will pick you from your hotels at 6:15 to bring you to the Hilton Hotel at 6:30. Hilton Hotel is much more central around the areas that you are staying. And there will be I can promise there will be delicious dinner. And also for some of you who are interested to shake your shoulders, we'll have also the cultural events already ready there. So it's a time to test yourself. As a summary of the entire day, Please do not forget during this dinner to carry your invitation cards with you. There is a good possibility when you go to your rooms now, you might forget. Please spend much time in remembering that as well. Tomorrow we start at 8. Well, we normally start at 8:30, but we have appreciated, and all of you deserve a medal because all of you today morning came much earlier than any one of us, and we're very happy with that. And in general, yes, earlier I've been mentioning about the number of tweets and impressions we have got all over the day. We have here 500 plus participants attending directly, and we have seen by the hashtag mom and baby, more than 1 million impressions over the day. And close to 500,000 accounts are reached by this hashtag mom and baby. And similarly, the @AOTC 2017 also received above 10,000 impressions right in this afternoon. The live tweeting by our colleagues from Crowd 360 also shown as an impression of about 153,000. We are flying millions, we are flying thousands to save thousands and millions of lives. I thank you so much, and there are more interesting issues for tomorrow, and I hope I will see you tomorrow morning. Thank you so much. Have a very good evening. Only housekeeping announcements. There are some people who have lost their items, and if there is anyone who have by mistake taken their bags, maybe they have swapped, we have lost our colleagues' bags which have a car key inside. Please, if you found, you can give it to the security right at the door. And one of our colleagues have also lost their phones here in front as a precaution for all of you. And if anyone has picked it, please give it to the security. Thank you so much. Shuttles are outside for everyone. Thank you.